So he's also the one of the writers of the latest guideline that's published recently.
Okay, first of all, thank you for the invitation here. My name is Pascal. I'm from Jessa Hospital, and if my slides are on, I'm talking about MICS and MiECC, basically the combination. We do in Jessa Hospital. In 2013, we attract a cardiac surgeon, and we are performing now up to nearly say 100% of MICS, and let's say also nearly 100% of minimal invasive extracorporeal circulation. I will close. It should be okay. Okay, here we go. So first I will start with the introduction of CBP. Everybody shows nearly only Gibbon. I was a few days later, but still we came a long way. Also, we all know the drawbacks of the conventional extracorporeal circulation, and we try to avoid that. Then there is also, if we look at MICS in 64, there was Colonel Kolesov, who was doing a Lima on CX on a beating heart, left thoracotomy. Maybe this was the first MICS procedure, but still also we came a long way. First, I would always start with the present. This is an old slide, always talking about heterogeneous systems that are existing. It's without venous bubble trap, it's with a lot of tubing, also mentioned previous, low penetration, as we all know, beneficial effects in CABG surgery, but also involved now. It's getting more and more, but still venting is present, air-blood interaction is present, so that also is very interesting. This is then the publication by Professor Anastasiadis in perfusion. It's nearly at classification, the 4 types. I think we all know them. I think we'll go roughly through this. For the presentation, I have two ways. It's a mixed CABG and then mixed valve. So first we're going to do the mixed CABG as we do it. In the right corner, you see that we can do it on an ECMO console. The thing is, it is possible, it is technically possible, we don't have any safety, so be aware of that. But still, why do we do still mixed CABG? We started also off-pump in our institution, and then now we're going to do everything, let's say, anterior wall, Lima LED, we do on-pump, empty beating, no-touch aorta. So that also switched our approach. This is then, let's say, the procedure of the endo-ACAP. This is an off-pump procedure. Go roughly through it. First, it's all been the thoracoscopically harvesting of the memory arteries, 3 ports, 3 working ports. Of 5 millimeter, and then it will make a small thoracotomy, left thoracotomy. First, you will take the memory. Okay, you see the 3 working parts, then a small left thoracotomy to put the anastomosis under direct vision. You see, then it's a stabilizer. This is how we started in 2013. You see, coronary shunt, and then the anastomosis, remove intracoronary shunt, and that's it. So all through the small left thoracotomy. This is then the cosmesis. Why I show this? Because it's very important also if you look at the numbers. We started 6 years ago and 350 cases a year. Now we doubled it due to minimal invasive cardiac surgery. So we doubled the amount of patients only to minimal invasive cardiac surgery. So if you look at the endo-ACAP off-pump, as you saw in the video, we do a Lima prep, thoracoscopically, left thoracotomy, direct vision, and no-touch aorta. If you do a MiECC assisted, as we do it now, it's remote access perfusion. It serves fem-fem, and just put them on empty beating. It's a type 2. Why do you use type 2? We also have a hybrid system, but this is basically fun to do. It's easy, it's safe. And also, this is then a different brand. This is then the one from Medtronic. But why do we do now with off-pump, and why do I mention it? The purpose to add MiECC is basically, it was also mentioned as after my abstract presentation at the ISMICS in New York. Sam Bauke and Mark Uel were also discussing with the floor If you have patients who are, let's say, severe lung disease, single lung ventilation is not possible, morbid obesity, what would you do then? Would you still do MICS, or what would you do? And there were a lot of people saying, yeah, then we do a sternotomy, which I find quite a pity, because you have the knowledge, you have the skills, you have the instruments, and then because of, let's say, single lung ventilation, you can't do it. But just put them on, let's say, a type 2, you lose around 0.5 gram per DL, and you can do your minimal invasive things. You see also the anastomosis, small calcified vessel, intramural LED. Those are the difficult patients. I will not convince them to do everything on pump, let's say, but those in particular high risk of difficult cases, it's easy just to put them on FEM-FEM, put them on a small pump, and do a minimal invasive cardiac surgery. This is then for the endo caps. The number of bypasses is slightly higher. It's not much of a difference. Only the hospital stay is quite important for us. It's 8.8 days. It's not much of a difference between, but still, if you look at the average in Belgium, we, let's say, win around 30 to 40% because they go home very early. I would all say it's because of the pump. No, it's not the pump. It's because of the MICS. But it's a strategy that that I think will work. Then that was the MICS cabbage part. Let's also go for the aortic valve part. So this is how we started, let's say, before 2013. Then we did a mini AVR. Mini AVR is basically how we call it, the partial sternotomy. It's just you see the aorta. The thing is, it's marked in red. It's a pulmonary artery vent. This is quite important. If you have a pulmonary artery vent or pulmonary vein vent, makes quite a difference in your circuit. So we use it in MiECTiS, type 2 or type 3. TE, automatic knotting device, is very important. Also for your skin-to-skin time. With partial sternotomy, stented valves, we have a skin-to-skin time around 70 minutes. So this is then we use a type 3. Type 3, basically, as you see, if I can see this one, this is then the back, as you see it, for volume management. Those are the safety lines. This is the venting part. Just go through an air chamber for air. This is the venous bubble trap. If air comes in, it will automatically be moved. So this is quite safe. If there is air, it will be automatically moved. I don't have to do anything, which I quite like. This is type 3, then basically venometronic part. You can switch from components. And then the results we see in the AVR, aortic cross-clamping, now for 45 minutes. Now it's around 30 minutes. But still, ICU stay, post-operative stay, 10.4 days with 30% of octogenarians. Also, the average in Belgium is 12.6. Still, we win some, still profit for the hospital. And I would always say, this is do the strategy. Basically, the surgery is priority. I think it's quite important. But I think if you have 30-40% of profit, I think it will be a 5-6% due to the pump, let's say. Then we also started in doing the conventional. Then we, as I mentioned, the partial sternotomy. And you want another challenge as surgeon, so we did then totally endoscopic AVR. So by the right, you see this is working. You have 2 or 3 ports, and then you have a small, as I mentioned, thoracotomy to get the valve in. This becomes quite different for a partial sternotomy because in a partial sternotomy you have a pulmonary artery vent, you have a pulmonary vein vent, so you need a totally different system. So this is a type 4, as also mentioned by Luca Diriu. This, as you see, is quite complex. You see all the components, you see a lot of tubings, also mentioned the Gunaydin system, a lot of tubings. This is then the type 4, basically. For the Medtronic part, still a lot of tubing. So what did we do? We made a hybrid system. You see the blue line going up above, it's not quite that long, but you see also the clamp here. Basically, now you're on a conventional system. If you put this clamp here, then you're a MiECTiS system. You can start MiECTiS. If you are in need of major bleeding or so on, just switch with using one clamp to a conventional system. And I think for safety aspects, for learning curve for perfusionists, this is quite interesting. I'm working in Hasselt. I'm also working an independent perfusionist in Brussels. It was basically see one, do one, teach one. This is basically quite simple. You need to make some compromises, and the only thing is the pulmonary vein vent, is some air, goes through your reservoir, defoamer, de-airing, and then to the small tubes in the dual chamber, it goes here, so you have a compromise of this small contact area, and that's it. But if you have a bleeding, if there is anything, just convert, and it's very easy and quick. This, in the totally endoscopic part, we did 103 consecutive patients, isolated aortic valves. We have no exclusion criteria, none. Aortic cross-clamping times of, let's say, nearly 1 hour. Also post-op blood loss around 200 mils. We do not stop also anticoagulation. So if there aren't dual platelet, we will continue. That's how we do it, let's say now in our hospital. Post-operative blood hospital stay is 8.3. The other one was 10.4 with 30% of octogenarians. This is all, again, profit for the hospital. So also the learning curve, because it's endoscopic part, if you look at the first 10 and the last 10 patients, there is some learning curve. Also, let's say for the team, ICU stay, the turnover is much higher, but especially I think the hospital stay remains very important. So the advantages, they say no pain post-op, shorter ICU stay, early rehabilitation and return to daily work, which is also very important. Endoscopy is available and let's say quite cheap in comparison between a robot. That's also very important. And cosmesis. So to keep it, always say, keep it safe and simple. To keep it simple, also the surgery and the let's say the circuit, keep it safe. This is how we do, this is an arch, this is a total arch that we do, just subclavian. We do then, here at the lower part, this is the venous cannula, this is the venting. So this is an arch replacement with the same, let's say, hybrid system at the back. So it's not a complex system to have all the drawbacks of all the complications. This is just, as I mentioned, keep it safe and simple. This is then the difference between a pulmonary artery vent. If you have this, you can put it straight into your venous line. If you have a pulmonary vein vent, then you need this one. This is the hybrid approach, venous bubble trap, and this is the reservoir. This is here, will connect the pulmonary vein vent. As I mentioned, cardiac procedures for us, we started then 350 in 2012. Then Dr. Hilmers joined us with MICS approach in 2013, and we're going up now in 2019 for over 700. So the patients are not coming, let's say, for the pump, they're coming for the surgery, but I think it's the strategy that we can provide them with. So to conclude, you see, this is a lot of fluids going by the anesthesiologist, also the perfusionist. You need a team approach. So what you need is to give the patient what he needs. If there is a bleeding, just deal with it. It's a patient-tailored approach, also a hybrid approach. If you talk to Cabbage, we work a lot together with the cardiologist now. Let's say we do Lima LED and maybe the circ, and they will do the right stenting or whatever necessary. The MiECC, as mentioned also earlier, it's not a circuit, it's a strategy that you need to attend. And then a small incision is not, let's say, it's minimal invasive, it's something different. So what we try to achieve is MICS and MiECC together as a combination for the best possible outcome. What I would like also to show you, if I may, maybe is also an interesting tool. This is quite an experiment, what we are busy with. So this is then the pulmonary vein, the pulmonary artery vent in a Benthal case. So this is a different view. This is how you see it. But if you then go to the other side, you see this is then the pulmonary artery venting going straight into your venous line. So this is also the thing that we play a bit with. This is then the head cam. You see it's quite empty. Also in mitral case, we do mitral case, we do complex case, we do arches, everything with MiECC from a different angle for the different system. Let's say this is then the MiECC part 3. You see the back, you see the upper part venting, you see here the venous bubble trap, so all going through the pump. This is quite different if we look then to the aortic, and if I may just a small seconds, this is also the pulmonary vein vent. You will see if it's loading. So he will introduce, if you look at this camera view, this is the pulmonary vein vent. Voila. He will put it in like this. But then we use a totally different system. If you look at the perfusion cam, you see this is the reservoir, this is the hybrid system, and this is then the pulmonary vein vent goes straight into the reservoir. So the thing is, we use type 2, we use type 3, and we use a hybrid system. But in general, you can all do with a hybrid system. If you exclude the reservoir, you have a type 2, you have a type 3, doesn't matter. But still, I think it's representative for a lot of centers. I think the hybrid, I think this is, if we talk at this session in the future, I think this will be, in my opinion, the future. Because also last week I was sitting there with Christopher Schmidt from Regensburg, who was a surgeon, and he was mentioning the only thing that is interest of me is what's inside my field. Where does the sucker go? It doesn't matter. I think everything that's going in front of me, that's what's important and not the rest. We're also doing a lot of mix program, let's say. There's people are coming to our center just to learn the MiECC, and it's practically the same. If you learn about MICS, minimal invasive cardiac surgery, you're focused on the surgeon part. I think the combination is possible, but still I think it's an interesting way to see how to implement as MICS and MiECC. Maybe that's a question that Professor Gunaydin can answer, because he started with MiECC and then started with MICS, so first MiECC, then MICS. Is it possible even to do both, to start both? I don't know. So I would like to thank you for your attention.
Thank you very much. Very interesting presentation. Any questions?
I still find it hard to understand why through a mini thoracotomy to do a lima to the LAD you have to go on bypass, because of course cannulating the groin is not a harmless procedure, isn't it?
No, that's true. That's true, but I think we do about 750 groin cannulations a year. I think we have a stroke volume, I think nearly 1%. But still, also off pump, you can do to a left thoracotomy, harvesting the thoracoscopically the memory artery. But I also believe that we are blessed with a good surgeon. Also, that's very important, because we had in the past, we had other surgeons, and it becomes quite difficult. Also, partial stenotomy becomes, now he's going to endoscopic part, so I think we're also blessed with that.
My question is, if you got a good surgeon who can do a lima to the LAD off pump, why do you want to go on bypass?
Well, that's what I mentioned. If you look at the cabbage, if you have difficult patients, so they say, let's single lung ventilation with COPD patients. Single lung ventilation is not possible. That was the same question that was asked at the ISMICS, and a lot of people said, if that's not possible to go on single lung ventilation, to do off pump, then we go with sternotomy. And that I found very hard, because if you then put a small pump on FEMPEM of, let's say, subclavian, and you can do your minimal invasive procedure, you don't have to do a sternotomy. Because everybody says, yeah, like say a bypass, but a bypass nowadays is you lose around 0.5 gram per DL. Okay, you have your FEMPEM, that's true, but still.
I understand your point, but let me give you a little hint. You can do lima to LAD off pump through a mini thoracotomy with both lungs. That's how it was conceived originally.
Yeah, but also if you then do, let's say, through a thoracotomy, the multivessel, it's also possible to do just on a small pump, multivessel disease, 3-vessel disease, through a small thoracotomy on the left. So I think, yeah, it is possible, but you get a good remark, yeah.
Yep.
Can I make one remark? If we're talking about off pump, then we also have to talking about graft patency and graft free occlusion rates. And there's not only the Ruby trial, there's also the DORS trial, and probably even for the right artery SEA bypass, it could be a good idea to use a hot lung machine. And if you use then a minimal invasive hot lung machine, you don't lose all the disadvantages, or you don't have that big disadvantages like in the conventional system. So it also could be a good answer for that patients, even for the right grafts. Just comment.
Yes.
Can I make one question?
Yeah.
To Paolo? Yeah. Stranieri. Yeah. I'm considering to target mitral valve repair with MiECC. Of course, you need the femoral cannulation for doing that. What is your experience? We have done few cases for minimal invasive AVR with thoracotomy, with femoral vein drainage. What is your experience? You've done a lot of cases with that.
Well, we do about 50 cases a year for mitral valve. What we do is mitral valve repair through endoscopic, through 3 working ports, with just a ring with a plasty. It's we do double cannulation, so we do jugular and femoral, because he doesn't had the possibility of working thoracoscopically to put the atrial ejector in. So he puts 2 stay sutures in the commissure to put the valve. But for the pump, basically, if you do like a hybrid system, you have your sump, is going through the valve. It goes through your, let's say, if I can go back to my slides, I don't know if it's possible or not, but I can show you. Is it possible to go to the slide? Because I have the drawing there. Okay, sorry. But the thing is, below the reservoir, because you have your venting going through your reservoir, you lose volume, and you need the volume. So what we do here, this is the EVO. which is on the S5. So basically, what comes in, you put it on percentages, goes out. So it makes my job very easy. Just what comes in goes out, and that's it. So you have a steady state. You don't have any flow going up and down. But still, it's perfectly possible with a hybrid system.
Yeah. Yeah.
Vadim, it's your turn. Your comments.
No?
Okay.
Yes, we use the same technology. We use the same technology, like in Jesse Hospital, with Hilton, with Center. We begin it. First time I met it after ECTS at 2015, and it was other technology. It's improved after that. They use CPB, fem cannulation, and next switch to cardioplegia, and next switch to use direct approach. It was good, and we skilled in this center and training in 2017. Yes, really. Anesthesiologist, me, assistant, surgeon, nurses, yes. And then implement this technology in our center. And MIECTiS system was the first option. And now we use type 2 and type 3 system in our center. It was good. And in this year we have Russian event, MICS, and we invited this team from Belgium, from Hasselt, and we did live surgery in our center, 2 cases, endocabbage, Pascal, Aladdin, nurses, and assistant. Yes,
and the endoscopic
endoscopic
aortic also.
It was good, and many guys from ATS watched it. It was very excellent and amazing procedure. Yes.
Thank you for the comments. You know that Bob Kiaii couldn't make it. There was a problem. So a final comment from me, and then some people didn't speak, and I want just a comment from the rest of the guys that didn't speak for today, is that technology is good, but for me the best technology is go back to the basics and apply physiology. This is what I always say. So we have 2 anesthesiologists and 3 perfusionists didn't speak at all. So a final comment. Yes, Amer is smiling. So comment from you for today.
Thank you, Kyriakos, for first of all inviting me and asking me to contribute as well. The theme that seems to be coming through consistently here is that it is all about teamwork and preparation of the patient, case selection, the way the perfusion is done, the way the anesthesia is conducted. And I think this is the most important thing that we need to take across. There are 2 aspects of the thing that have come through the day. One is the actual technique itself, which I think many of us are familiar with, but there seems to be a shortage of training opportunities for our perfusionists and our anesthesiologists to actually learn how to do the techniques. And that then becomes this chicken and egg situation that not enough people get a chance to see the technique, to do the technique, to learn how to manage complications of the techniques, and therefore there's a reluctance to then start taking on the technique in the first place. So one of the things we should probably seek to do, which I think we spoke about earlier, is to maybe try and increase the opportunities of training perfusionists and also anesthesiologists and surgeons to see or go to a unit, spend some time in a unit where these techniques are being done and learn how to manage them and learn how to manage complications, and then take away, if you like, some of the fear of instituting a new technique for the first time. Because the worst thing that can happen is whenever you start a new technique in your hospital, a disaster happens, and that will kill the process. Nobody else will allow you to do that again. Any comments?
No, thank you.
Thanks.
Helena?
I'm very happy that everyone appreciates the contribution of anesthesiologists to optimize surgical results. And it's, of course, it's teamwork. And I personally believe that we can contribute to a better results for the patient.
Thank you. Apostolos?
I think MIECTiS maybe is a complex and mandatory technique, but for me is the only way to perform more physiological perfusion. And if we need to apply more physiological perfusion, then MIECTiS should be integrated into clinical practice guidelines and be the standard guideline for perfusion.
It's already there. There's a standard guideline, but anyway, it is in the guidelines. So, Hans-Jörg, please. Can you switch off your microphone so we can hear? Yeah.
Okay, my approach is a bit different. So, well, I think we do a lot of give a lot of courses for mini bypass as well. You know that for Medtronic, and what I found out in the last years is the perfusionists are a bit afraid about the risk and so on. And what we try to achieve is to simplify the systems, because if you want to really follow 100% away from the MiECs, from the ground ID, I mentioned no blood air contact and so on. I think sometimes you have to make compromises, you know. And we will see in my presentation from tomorrow, you have to speak more with a surgeon, for example, how to suck and so on, so it can perhaps make the system simpler as they are for the moment. Sometimes they are really complicated, and perfusionists, they are a bit afraid about that. So that's our goal, is to simplify the technique in the future.
Thank you. So, Professor de Sommer, Philippe.
I think I would agree with training that certainly is an issue. But I also would agree with what was just said, that simplifying the system is also very important, because some of the systems now, if you see them, they look very complicated with a lot of lines, and this is a barrier. I think what Pascal did, for example, makes things simpler. I think if you make it simple, but without jeopardizing the basic concept, that would be a next step, and there the industry has certainly a task.
Okay, thank you. So you heard from everyone some comments on what we discussed today. I think it was quite interesting, and we can have it on demand so as we can draw conclusions for our next section tomorrow. Just to tell you that so far more than 7,500 people viewed this event, and this is a great, let's say, result for the first day. And I will leave it for the president of MiECTiS, Professor Merkin, who would close it and say his own remarks for today.
Good. Well, I'd just like to echo all of the comments. I think the interactive nature of this particular meeting, the multidisciplinary focus that we're bringing to these issues, has really helped to determine how we move this process forward. And I think, as Kyriakos has just identified, I'd like to also thank the organizers and the media company, Live Media, for doing this, because I think the fact that we have over 7,000 people that have participated in part of this meeting is really a testimonial to the whole interest in this area and the ability to really gather truly a worldwide audience. So on that happy note, I'd like to thank everybody for their participation so far and remind you that we'll be starting tomorrow at 9 a.m. So thank you all very much. Have a good evening.